This is the second webinar series in the Collectivity and WHO Joint Venture for Strategic Purchasing for Health Systems Governance. So there'll be a number of webinars across this series, and those who had joined previously will have heard Aurelie speak about this. Aurelie, I believe you're also going to give just a very quick introduction to the series, is that correct? So we will have two speakers today giving a presentation on the health system reforms in Indonesia. We have Dr. Firdaus Hafiz, who is a specialist in health financing and health insurance management, and a researcher and lecturer at the Department of Health Policy and Management at the University of Indonesia. We also have joining Dr. Hasbullah Thabrani, who is the chair for the Center of Health Economics and Policy Studies at the University of Indonesia, and also a consultant on the national health insurance reforms within Indonesia. Once Dr. Firdaus and Hasbullah give their presentation on the recent reforms to JKN, the health insurance scheme in Indonesia, we'll have our discussant, Dr. Luis Pinaltore, who will be posing some questions and giving his own thoughts as a representative of WHO Sierra on this recent insurance reforms and how they relate particularly to the Southeast Asia region. So without further ado, I'll pass over to you, Dr. Firdaus.
Hello. Maybe Firdaus not joining. I'm Hasbullah Thabrani. I can start with the presentation first, and then Dr. Firdaus will join later, maybe. Is that okay?
Yes, that's fantastic. Thank you,
Okay.
Dr. Hasbullah. And sorry to interrupt you. I must also say as well for the participants of the webinar, it's important to note for everybody to please mute your microphones while we are speaking, unless you're speaking, and also to note that we'll be posing some questions to participants in the chat function. So if you monitor your chat function, you'll be able to engage in discussion alongside the presentation and also to raise any questions that you may have throughout the presentation. We'll be allocating around 45 minutes maximum to the presentation, and then we'll have approximately 15 minutes to field further questions. So thank you, Dr. Hasbullah.
How many minutes for presentation?
We're aiming for between 35 to 45, and I will give you a few time prompts if we think that time is running out.
Okay. You help me to change the slide, right?
Yes, Danielle will be helping.
Okay. Thank you very much. Hi, everyone. Would like to start with the explanation about the health system of Indonesia and where the JKN, the national insurance fits. It is and then current situation and challenge of the JKN, and then after that, Dr. Hafiz will discuss more detail one of our current project on strategic purchasing on tuberculosis cases. Next slide, please. This is the division of labor, if you will, under our health law. We divide two different functions for health system. One is what we call it public health system. Public health meaning the recipient of the services are a community, not individual. The focus on promotion and prevention. This system is managed by the government and funded by our tax system or national budget. In this public health system, we decentralize the policy and implementation to local governments. We have 540 local government at the county or municipality levels and 34 provinces. For the personal health care, which is focused on diagnosis, treatment, rehabilitation, we developed this system with combination of funding from social health insurance contribution and tax subsidies for the low income. This system is managed by different public entity. It is not by the government. It is a parastatal entity. It is public because it's established by the state, but it is managed as private entity. So that's the difference between the BPJS and the government. This BPJS, which is the administrator of national health insurance, if you will, is actually the purchaser for personal health care. The provider for personal health care can be government, national government, or local government that own healthcare providers. It's called public healthcare providers. And also private healthcare providers. So that's the way we divide it. Next slide. Why we developed social health insurance? Because since 55 years ago, that's almost half century, more than half century, we started our funding for health system within the public sector using the social health insurance model. And then we developed expanding to private employees and expanding also to social assistance program for the low income with different providers or different agency manage different health insurance schemes that provide inequity or injustice by our constitution, because different insurance mechanism and social insurance provide different benefit package, different mechanisms, and also different contribution level. Our constitution in 2002 was amended to require social security for all Indonesians. And then we wrote the law of currently being implemented as national health insurance as the integration of all of those social health insurance and social assistance program into a single payer system that currently cover 224 million people, or about 84% of the population, under a single database, a single system. But that's coverage, basically registered coverage. It is not necessarily really protected. I will explain later about that. So we started this integration in 2014. That's already 5.5 years ago. So we will present some achievements, some challenge and problem. Certainly for the future, we will expand to cover, to manage health risk later on. Currently, this system manage risk by mostly healthcare services funded by the BPJS. Next slide. The grand design of this system is a single pool. Why? To ensure equity across different groups. In Indonesia, we have 34 provinces. We have 720 different ethnic groups, different languages, but we have national language, and they are scattered in more than 5,000 islands. So we developed this single pool to ensure that everybody contributes and receive the benefit with the same procedure. That will be easier for our population who are mostly lower education to understand everything. Certainly, administratively, the BPJS, the administrator, has branches all over district and cities. The risk pooling mechanism and risk sharing financed by 5% contribution of wage earner or salaried person or formal sector, if you will. We use the term wage earner. And for non-formal sector, we call it non-wages, they can choose 3 options of contribution, which is set as nominal amount that relate with 3 different hospitalization scheme. And for the low income, the government subsidizes with fixed amount of money per person per month. These subsidies are now cover 40% poorest Indonesia, which is about 100 million people or more. The benefit that we provide through this national insurance simply defined as medically necessary or comprehensive benefit. The historical benefit is this comprehensive, is that since we apply social health insurance, we adopted what the US call managed care technique, which is actually similar idea with strategic purchasing. We pack certain services, we pay with different payment, prospective payment, determined in advance, and we monitor the quality related to the payment. So we use this model, provide comprehensive benefit for all individuals to ensure equity across different groups. The services are provided through contracted public and private healthcare providers. So although the system is public finance, but the services can be accrued in the private hospital, not only the public hospital. So we ensure efficiency since the beginning. The JKN use our traditional managed care concept, which using gatekeeping system and pay primary care providers, both public and private, using performance-based capitation, which is related to the output and some outcome, intermediate outcome. And for hospital care, we pay using case-based group. Basically, it is modification of the DRG system. Only small portion of the benefits are paid on fee schedule, mostly on the package price too. Next slide. In terms of pooling and sharing function, the wage earner share contribution, unfortunately, with low ceiling of salary to be calculated as a contribution. This provides problems up to now. So private employees contribute only 1% of their salary, and the employer pay 4%, while public sector employees, the government employees, both national and local, contribute 2% of their salary, and the employer contribute 3% of salaries. In this group, the wage earner collection have been almost 100%. It is good collection since the payer actually the employers who are easily mandated and contribute. For non-wages earner, we set 3 different classes contribution where the family can choose from with expectation that they choose lower class, which is the class for lower income, and higher class, first class hospitalization for higher income. But it turned out in practice not the case. In this group, collection of contribution highly problematic. I think there are many article, there are many research showing collection of contribution by informal sector always problematic, and therefore in our experience it's just average above 50%. This can be problematic until now. For the low income that the government subsidized, government contributes only 23,000 Indonesian rupiah, is about 1.8 US dollar per capita per month. This is too low, but the government at that time, 3 years ago, insisted that they wanted only to contribute to 23,000. By law, contribution and the ceiling of wages are adjusted periodically, which is in our plan is every 2 years. Yeah. However, it is not always the case. This adjustment is important to adjust income increase and price increase. Next slide. The purchasing function of our system, as I mentioned before, adopted strategic purchasing in terms of capitation, package price. We use also e-tender for drugs to ensure that we get the best price for a given drug for the non-patent drugs, and we negotiate price of drug for patented drug. With the high volume, we can get better price for our members. So this practice actually is already started in the early 80s. Sorry. The JKN use integrated social health insurance and social assistance to avoid stigma of scheme for low income and scheme for the rich, or scheme for blue collar or the white collar. So everybody has the same scheme, and we expand capitation payment and CBG payment nationwide to all hospital and primary care. Currently, 2,400 hospitals are contracted and 22,000 primary care are contracted. Nationwide, they pay the same price, the same model, the same about the same amount of money. A lot of price differences to adjust with local costs. The agency under Ministry of Health, it's called PPJK. Basically, it is a Center for Health Financing. Is established to evaluate and calculate prices simulated with the expected revenue. So that creates some problem later on because they don't use the market price. To ensure that new technology can be covered, we also have a commission of health technology assessment within the Ministry of Health. National formulary has been working and still continue to be used because we already use it in the 1990s. For the drugs, to ensure we have a better price, we set up an e-tendering process. Basically, every pharma company can submit their products with related price for each province, delivery at each province, and then we sort the lowest price as a winner. So we still have some problem with this strategic purchasing, although we already use a very strong cost control, creating change in management in hospital, but there are still room for improvement. And currently, we are continuing with improvement with strategic purchasing. The next slide, current achievement. Next slide also. We can see here the two graphs showing the increase of population coverage over the year. By the end of 2018, it's covered 200 million. By last month, the JKN covered 224 million people. And in terms of revenue in Indonesian rupiah, so our system pump the health system with 82 trillion rupiah. It's about 6 billion US dollar a year. Next slide. The distribution of the member, however, you can see that the red pie consists of the government sponsor, or they don't pay, but the government, national government and local government pay for them with low contribution. The wage earner for private sector, the second, and also the third group is the non-wage earner. Yeah. Next slide. This slide just showing you that our evidence that this system works by using utilization rate. Utilization rate is a proportion of members who consume healthcare and claim through this system. So we can see here for outpatient increasing quite significantly from 20% at the beginning now to about 55% of the members utilize the outpatient care, with inpatient care increase from 4% to 7% of the members were hospitalized, and also for drug, probably using drug increasing. This increase showing that this system protect people from impoverishment, but some higher income group from our check often opt out. They contribute, but they don't use it. They pay out of their pocket to avoid long waiting, long queue. Next slide. The main challenge for us is that the lack of understanding of this is the overall concept and implementation of JKN by the policy makers and also legislator, resulting in consistency in the implementation. What I mean in inconsistency are contributions set with greater political consideration instead of technical know-how of social insurance principle. In the insurance principle, contribution should be set by first calculating how much money needed to pay or to purchase services from healthcare providers, and then we translate into contribution, distribute to all people, to all members, depending on their income, and transfer into proportion of income. But the practice, because of the political consideration, works better. The government just say, I want this much. So that's what I meant by political consideration. Similarly, pricing for healthcare providers mainly by expected revenue, not by first calculating the market cost or the average market cost of providing services, but it's rather top-down government set. So that's another problem. Price adjustment has not been made regularly and timely as stipulated by the regulation. The second biggest challenge is the tariff, the price, especially to private providers, because the price setting is not consistent with the law, creating low price, and the private providers reacted with doing some restriction or some quota for our JKN members. That in the end will provide barrier to access. The capitation payment, for example, has not been adjusted for 6 consecutive years. This is certainly not good for the primary care, because inflation in the 6th year already reaching 30%. And because of the 5 years consecutive deficit, the BPJS under pressure to control costs, and therefore BPJS often provides some requirement for the people to register or for the payment of the claim from the providers, creating a lot of complaints of this system. Next challenge. We are debating about deficit, and a lot of people complaining deficit. In my view, the deficit was intended. I call it the politics of deficit because since the beginning, the Ministry of Finance knew that the contribution level they set will not be adequate, but they do it. They did it because they consider that if we give more money to the BPJS, they might not be prudent. So we better give it lower. In the end, they will meet the deficit anyway. And while the deficit happening, they're blaming the expenditure, the flow of outflow main problem. They don't really see the inflow problem. For example, contribution for government employees was taken from the basic salary only, not from the take-home income. While the basic salary is only about 10 to 15% of the take-home income. When we studied at the beginning how much the contribution should be, which is about 5%, was calculated based on the survey of, at that time, 2012, that on average, employer pay 5.2% of the labor cost for the contribution. Next slide. This is another slide demonstrating that our total health expenditure per capita is still very low. In 2015, we spent only $30 per capita per year, which is very low, very low. So, and therefore, we have big problem with this financing. Next slide. So, I give some discussion on this, what we call it, stunted JKN. Stunted JKN or severe anemia of JKN. That's because, hello? Hello? Yeah, that's because...
Yes, please continue.
Yeah. That's because the JKN basically underfunded. I can compare it very easily. Population coverage already reaching 84%. But if we look at the contribution of health expenditure by the BPJS to the total health expenditures, only is about 15 to 18%. That means we have a very big gap on this one. And therefore, there are a lot of attention with that. Currently, I'm working with ThinkWell. It is a financing agency funded by USAID to improve sustainable financing. Sustainable financing meaning there are balance between revenue and expenditure. So we work with the revenue side by studying what is the source of revenue, where the source of revenue, how much they did, and how we mobilize more resources domestically. But also we have to look at the expenditure side by implementing strategic purchasing. Currently, we at the ThinkWell are doing two different projects. One is funded by Gates Foundation for strategic purchasing of neonatal maternal health, and by USAID covering three different USAID priority of disease, which is tuberculosis, maternal neonatal health, and HIV/AIDS. For the next presentation, Dr. Hafiz will discuss more detail for the TB only, just for an example of the model. I think, Hafiz, over to you.
Hello. Thank you, Professor Hasbullah, for your presentations. Good afternoon, everyone. I'm Hafiz. It's an honor for me to be here presenting Indonesian experience of strategic health purchasing exercise in Indonesia, how it can be change the behavior of the provider for higher quality of care in TB services. So next slide, please. Next, please. Yeah, next, yeah. Okay, so there are two phases of the strategic health purchasing support from the development partner to Government of Indonesia. For the first phase one, it has been started since November of 2016. Through the technical working group consultations, the R4D were introducing strategic health purchasing and to make sure that they have the same understanding of what is strategic health purchasing. So Indonesia's government has been decided that strategic health purchasing is the ability to purchase preventive, promotive, curative, and rehabilitative services to improve the health of community members to get the maximum results. So here's, as we understand from Professor Hasbullah's presentations, we need to make sure that we have a clear understanding of the context of the institutional structures, roles, and responsibility for the strategic health purchasing. For example, what to buy, from whom to buy, and how to buy. As Indonesia have both purchaser from Ministry of Health and BPJS Kesehatan, it seems that we need to find out what's the regulations has been done and what's the responsibility of each organization. Next. The development partners, including R4D, has done the review of regulations, stakeholder interview, and the technical working groups meetings, and they found 102 laws and regulations and decrees related to purchasing under JKN, and it's found that there's a lot of regulations that's not quite clear, and there's some of the BPJS Kesehatan seems relatively passive as purchasers. Next. From this diagram, we can look, I just tried to, I'm sorry if it's too small, but according to the current regulation, the Ministry of Health seems have a majority of the functions, including the strategic health purchasing. So the Ministry of Health mandate to protect the health of populations, set the clinical standard, regulate the benefit package, and set the tariff, while the BPJS Kesehatan authorized to do the contracting and reporting. So it shows that the Ministry of Health have more power. But in 2018, there was a new regulations that they encourage the BPJS Kesehatan as the purchasers that they can do any policy for the better have purchasing functions. Next. In 2016 to 18, there's also to have validate and disseminated the findings of the regular review. With the R4D team, they facilitated the serial meeting with the technical working group of the strategic health purchasing to ensure they have the same understanding and what need to be done in the futures. In addition, the technical working group also do the capacity building to make sure that they can implement the strategic health purchasing for the second phase. So in the second phase, next slide, please. Next slide, please. So the phase two, it started since August 2018 till today. So we are working on the operational policies and the systems, how our purchasing function carry out, including the contracting, information systems, monitoring systems. And as Professor Hasbullah also discussed, that we are now focusing on the priority programs, including tuberculosis and maternal neonatal health, to refine proper payment system to improve priority programs and improve use of data that are available already. So at the beginning of the process, we identify the service delivery objectives and assess whether the current purchasing of arrangement, which is INA CBG and capitations, have given incentives to support the objective of TB service delivery, for example, TB notification rate and TB completion successful rate. And at the end, we hope that we can do also capacity building to have the sustainability of this exercise of the governments and the BPJS Kesehatan and academics. Next. So this slide tries to capture all of our approach for design new policies related to the strategic health purchasing that process-driven is the objective to improve service delivery and health outcomes, the design of solutions of the stakeholder experience and consultations, and what the final policy options to inform the locally driven analytics. So here we identified that there are two main points of the objectives. There are to increase the notification and successful rate of TB services, and then reduce up referrals from primary to hospital level. Because nowadays it seems that there's, due to the capitations and lack of the awareness of TB services, most of the primary care refer to hospital level, especially for the private providers. So that's the main concern of the NTP, National TB programs. Next. So thanks to the governments of Indonesia that they have their leadership and commitment to do the strategic health purchasing. Also here the organogram of the strategic health purchasing working groups. There are four main groups. First is the steering committee, which is the higher level position in the Ministry of Health, including Secretary General and Echelon 1. And then there are core working groups. This is basically three main stakeholders, which is the PPJK, which is the main coordinator, Centers for the Health Financing and Health Insurance, and then BPJS Kesehatan and respective directorate. In this case, this is National Tuberculosis Program. And there are technical working groups. It's including the professional association, health facility associations that provide recommendation on the strategic health purchasing. And then there's technical supporting group, which is mostly from the development partner, including the USAID health financing activities, the R4D through the tuberculosis private sectors, and World Bank, which is also they have their activities to support the strategic health purchasing. Next, please. So the discussions of the technical working groups are addressing purchasing holistically, meaning all purchasing functions in the gray area, which is financial benefits package, contracting, provider payment, and monitoring, are being assessed in terms of current conditions, challenge, and opportunities to leverage the health system result. Next slide. So here are the process that we have started since March 2019 to kick off the process, and then doing the analytical plan to find out the main problems, and then find out the benefit package, what kind of provider payment mechanisms should be paid in the benefit package, what kind of contracting, and in the current status, we are preparing for the fact-checking before the policy recommendation and concept of collecting and monitoring. Next. So here are the benefit package brainstorm. So we tried with a simple template of diagnostic and in summary, all stakeholders agree that primary care facilities. So the access to comprehensive TB services at the primary healthcare, both public and private, and strengthening the horizontal and vertical referral systems, including the TB resistance satellite, TB drugs and medical supply subsidy, especially to private providers, and specimen transportations. Next. And this is the second brainstorming. here more complex discussions. We identified what kind of payment mechanisms in different type of health facilities, including district health office as the purchaser, and also pay by type of the benefit package. Next. So here are the preliminary results of the consensus in the technical working group using the fishbone diagram. We found that there are kind of consensus of unbundling the TB services benefit package from the original benefit package and payment mechanism that has been in the JKNs. And also we add some indicators of the treatment outcome and notification as the basis of the payment. But however, we also need to find a good balance to give incentive for improving the service delivery objectives, but also not administratively burden for the purchaser and the health facilities itself. Next. So here's the last discussion about the contracting. Here we discussed the contractings, and it's good to hear that there are some innovations should be made in the contracting. Apart from the contracting between the BPJS Kesehatan and the health facilities, but also governments also need to be there and as part of the contracting to ensure that they can achieve the policy objectives. So link it to policy of the essential health package from the Ministry of Home Affairs also will be really good in the contracting and force the head of the district levels to meet their target of TB service coverage. And BPJS Kesehatan also agreed that they can use their power to encourage health facility to do reporting for specific program, for example, that will affect the reimbursement to health facilities. Next, please. So after we did also pre-testing of the strategic health processing by visiting health facilities in Yogyakarta, there are 4 criteria that we assess that we should be need to aware of the policymakers and BPJS Kesehatan, that we need to make sure that it's technically valid to improve service delivery objectives. However, we need to make sure that it's not administrative burden and indeed to have a BPJS Kesehatan budget to make sure that it is efficient and effective. Next. Next, please. So here are the main issues that we address for the next by doing fact-checking in the district to validate the policy options, what we have been discussed in the central level, and doing the mapping incentives for different providers of the key points in the TB diagnosis and treatment process. And we need to make sure that also in every policy option, there is a budget impact analysis to make sure that they can buy in all the policies. Next. So we still need to provide evidence for the governments and the BPJS to buy in all the policy options, including the district levels. And then the policy recommendation, including policy notes to the steering committee, need to be done for the consensus, and then do the pre-testings by the October 2019. It's also need to sensitize and training the district level, because we need to make sure that they understand of the interventions of the policy and purchasings that need to be piloted in 2020. Next. So to conclude that, I think the political commitment and leadership, technical expertise, and adequate resources to contribute to the surgical purchasing process is crucial. However, there's a lot of challenges. We admit that the different level of understanding of stakeholders and absence of health facilities and local governments at the beginning of the process. And I'm sure also the sustainability of the financial support of the surgical purchasing activity in the future is still questionable. And I hope we will be very happy to have your comments and feedbacks, and I hope this lesson learned from Indonesia can be used as a guidance in other contexts in developing countries. Thank you so much.
Thank you very much, Dr. Hezbollah and Dr. Hafiz. Very interesting presentation. I also want to apologize for earlier introducing the webinar. I think we had some audio issues both from Aurelie and myself, so this should be sorted now. I'd like to remind everyone that we do have the chat function open, so if you have any questions, please post them in the chat function, and we've also been posing questions for you as an audience. So please feel free to engage with those and share your own experiences of how you feel the reforms currently being taken in Indonesia and the JKN are relevant to your own country experiences. So I'd like to invite now Luis to give his impressions and overall discussion points and perhaps some key lessons for other countries to learn. So Luis, I'll hand over the microphone to you.
Okay, thank you very much. Good afternoon, good morning, and good evening to everyone. Laura, can you hear me properly? Just checking once more.
Yes, thank you. Can hear you fine. And could I also take the opportunity to remind everyone to please put your microphone on mute if you are not speaking. Thank you. Thanks, Luis.
Okay. Well, first of all, thank you for these fantastic presentations. I really like, I'm a fan of Professor Hezbollah doing presentations, so thank you very much. And also, Hafiz, very clear and interesting. I learned a lot. So I want first, as a first reactor, to share with you my 6 stay-home message. No, if I am taking the perspective of a country with similar challenges, what would be my take-home messages that I will take after listening the presentations? The first one, it's a take-home message. It's also some complementary views from my side. The first one, I think it's important in the very beginning when Hezbollah said, okay, the big design included kind of a tax funding, which implied funding supply side public sector, and then premium-based or contribution-based social health insurance for more the personal care. Well, I think it's important to take into account what Hezbollah has said later on. Now we have the main source of funding of JKN is tax money, which is to pay for the premiums of the vulnerable groups. So it's not that the tax money is not only used for public health related things, but also for personal care. I think that's important not to make an explicit automatic link between premium contribution, social health insurance, and personal care. Number 2, I think it's very interesting. Again, Indonesia is showing that informal betting on getting contributions, getting money from informal sector is very difficult. 22 years later, the Philippines has realized the same case and now is moving to a full subsidy with government money for everyone which is not in the wage group. I think that's a lesson that would be interesting for other countries to hear. The third one, and despite the JKN, one of the policy objectives is to tackle equity, very often contributions are capped for the high income groups. This defeats the purpose of stimulating cross subsidy between the richer groups by not getting a higher share of their income to contribute the social health insurance schemes. So this is, I think, something relevant to look when countries designing or reforming their own system. The fourth point that I would like to bring is the utilization rate. We have seen an increase, quite an impressive increase on inpatient and outpatient care, but I would say while the inpatient utilization reaching 7% is what would be more or less expected. For a reference, Thailand utilized 10%, the Philippines was around 4-5. So while this increase on utilization is good, I would not be that happy on outpatient care. We are talking about 0.5 which I'm not sure if we are talking of individual consultations or number of outpatient visits. But in any case, I think that we are talking a very low utilization of outpatient care. So we have a question, a relevant question there, why the JKN has not been stimulating the utilization of outpatient care as we would like probably to see. Just as a reference again, in developed countries in Europe, there are about between 8 and 12 consultations per capita per year, which translated into the Indonesian metrics would be 1,200%. Then an interesting point, which has been a bit hidden, but I think it's interesting, is the utilization of the medicines package. In CRO, in the Southeast Asia regional WHO region, the main problem of out-of-pocket and financial protection is medicines. So really tackling the medicines and outpatient medicines, it's a critical and too often and kind of misunderstood problem. If we want to tackle and we want to progress towards universal health coverage, we definitely have to do a better job on that. My sixth point, and I have only one more after, I found very interesting when Professor Hasbullah was defining the challenge, which basically you could put it in governance box. And if we take in a political economy frame, he mentioned the hospitals, which they were seeing the discussion on reimbursements as from the expected revenue side. So we have a big group there which is unhappy. Then you had the politicians, which they don't want to give enough money. So they say, okay, this is what I'm going to give you, and I will not give you more. So there was also, they want a sexy program, but not really happy to fund for it. So we have another big group. And then we have the Ministry of Finance, which recognize the problem of the deficit in advance when it happens. So I would put it is clear that the challenge, and therefore also the doors where we need to knock to address most of the problems and the challenges that have been described are political, are power positions. It's better, and therefore better understanding what are these power positions, who is with you, what are the intrinsic interests of every group, and probably surfacing this analysis could help tackling this challenge. And I'm sure Hasbullah could give us many ideas that he might have already. Then moving to the second presentation with Hadid, I think it's very important for countries to do this exercise that Indonesia did of looking at what the law said, the contradictions with rules, are we enforcing the rules that we have, and with all the challenges related to the regulation function, which sometimes we are a bit pretending, we have the laws there, but we are not serious enough for implementing them. And then my last point is, I think it has been clearly said, there is in these technical working groups, we are putting the right people on the table. Now we have the Ministry of Health with PPJK, which has the role of setting tariffs and revenues, and then the BPJK, which is the administrator, as Professor Hasbullah said. So, but then a bit is contradictory. What I'm saying is contradictory what I have just said before. We are putting the right technical people in the right table and putting them discussing, but then we are seeing that most of the problem are political, or governance. So how we could bring these two dimensions together? And again, sorry, very, very last point. I think that in the tuberculosis case, which shows, I think it's important to start showing the path of how to introduce the quality and effective coverage dimension of intervention or of disease within the provider payment mechanism. But there is, in the challenge in Indonesia, there is unanswered questions that are relevant for this. For example, all the funding coming from subnational levels. At the end, all these counties and provinces are funding health services through salaries and line item budgets. So basically, they are not funding specific disease. So how we are going to bring this last this unanswered question of the different flows of funding be brought to this discussion of tuberculosis. I stop here because I'm only the first of the discussions, and I'm sure we will hear a lot from colleagues. Over to you, Laura.
Thank you very much, Luis, and some very interesting points indeed. I have a question here from Michael Borowitz and Alex Winch from the Global Fund. Dr. Havis and Dr. Hezbollah, I hope you can answer. They have asked, please explain the pay for performance in primary care and what the indicators are for payment. Are you able to comment on this, please?
Can I comment on the response? First, on the informal sector, yes, certainly we are discussing a lot of options for that. We have not come to the conclusion. My work for the next 5 years will come to more detailed analysis and option available, expecting to convince the government that some option to ensure sustainable collection of funds will be available with a different scenario. So that's for the informal sectors. The easiest way, yes, the government pay all contribution for the informal sector that ensure everybody collect. But this require a lot of political lobby and also provide data analytics. The utilization, I am sorry, I didn't, or I forgot to explain. The utilization rate that I provided is just for outpatient hospital, which is for specialists. You might calculate, for example, for outpatient visit, 12 visits per year in developed countries where understanding is better, access better, no other option possible. Yes, that's high, but we don't include utilization for the primary care level. Which at primary care level, the primary provider are paid on capitation, so they already include the drugs there, their visit. They don't necessary to report of those visits. So we didn't include that one. For the inpatient care, yes, we have only 7%. Some other countries, Thailand, as you mentioned, 10%. This is increasing. We are still in developing. The reason for that is that this afternoon we have some discussion with the BPJS showing that about half of the population who already registered to the JKN actually have not used the JKN for various reasons. One reason is the long queue. Another reason, they have additional supplemental health insurance. And another reason, the providers are far from their house in the remote area, while also the culture still believe on the traditional medicine, so they didn't use it. Yes, it takes time to reach to that level. I think for the political economy, this is actually the hardest part. Technically, calculation, estimation, easier to do because we have more data now. We have claim-based data, we have population data, we do analytics, but convincing politicians, convincing people in the Ministry of Finance requires quite long process that not easily adopted at the beginning. In addition to that, complication of various news, media, comment from people who really don't understand the situation, but quite talkative and media friendly, often quoted by the journalists, create confusion and delay in convincing the policymakers to make a bold decision on this political economy. I think it will take sometimes, maybe 5 to 10 years more from that to get the maturity. If we look at the Philippines PhilHealth, which started in 1997, which is much older than JKN, the contribution of PhilHealth to the total expenditure is even much lower, still about 10% because of those political economy problems. Yeah, we noted that, we understand that. My work for the next 5 years will provide more analytics and more communication to policymakers, legal makers to improve this one, as well as to the public to raise awareness and to provide more pressure to the government to implement the JKN on the right way. I think that's from me for short. Over to you, Hafiz, if you have
Thank you, Luis, for your comments. I think you're right that this is the main problems of having the regulation functions of the tuberculosis objectives and what BPJS regulations does not fit each other's. I think that's why we are supporting Government of Indonesia to find out what kind of strategic health purchasing that might fit for both of them. Having technical working groups together at the right persons, yeah, I think that's the main things of this exercise, to make sure they meet each other's and having same understanding each other's. That's the biggest challenges, I admit. So, for example, nowadays that the NTP has their funds to do for tuberculosis program, while the BPJS Kesehatan also have their funding systems, and Global Fund also have their funding systems, and there's a lot of fragmentations here. So that's why I think having them sit together, discuss it together through these facilitations, I think it's a good way to have them. So I think by having them together, the tuberculosis cases quality and coverage dimension, as you said, into the district levels can be solved. That's what we expected. In terms of the question from Michael Borowitz, thanks for asking the questions. So most of the services paid using the capitations, and some of them are using fee for service, especially for the maternal and neonatal health. For example, for delivery, vaginal delivery, and then the family plannings. But there are no indicators of tuberculosis at the moment. So there is some indicators that's why we try to propose to the Government of Indonesia and the BPJS Kesehatan to put it, there's some option actually, to put it in the performance indicators, which is currently only 3 indicators, which is contact rate, refill rate, and the contact rate of the chronic disease. But then we need to make sure that it's also not administratively burdened. That's something that we also need to concern. Yes, I agree with you that the low tariffs somehow become the circle of the devil. So that's why we need to make sure that we need to identify the benefit package first, and then we need to make sure the tariff is fit and fine for the health facilities. So there's other options from the development partner. For example, the R4D, they try to propose the bundled episode package, for example, as what Taiwan has been done or Philippines has been done. But as you may aware, that Taiwan has been successfully to do the payment mechanism, while the Philippines seems that there's been struggling, in my opinions, about the tariff itself. And I think it's good to hear that from Mumbai of how they're engaging the private sectors in TB. I think that's also one of the challenges in Indonesia because of the Indonesians' behaviors to find the private providers at the beginning and at the end of the treatment also. Yeah, thank you.
Great. Thank you very much, Dr. Hafiz. We have one more question, which is from Julius Merck to Professor Hasbullah, who asks whether it's possible to strategically purchase without sufficient funds, or is this a prerequisite for strategic purchasing? Dr. Hasbullah, are you able to comment?
Sorry, I have a bad connection. What was the question?
So first of all, thanking you for your presentation, and then asking whether it's possible to strategically purchase without sufficient funds, or is this a prerequisite for strategic purchasing?
Well, certainly not possible. Strategic purchasing philosophy is to buy something, to purchase something which is affordable, efficient, but not sacrificing quality. So it is basically traditional managed care technique also has a similar way. The very important element often missing in strategic purchasing, which is the amount of money, the adequacy, or I always make it analogy of the dose. If we treat sick people in medicine, we need, for example, for headache, we need 500 milligram of paracetamol. So giving paracetamol is equivalent of strategic purchasing model. But if the price too low because the money is not adequate, we expect too much with the quality. It is similar to provide or to give somebody with headache with only 200 milligram of paracetamol. Certainly the headache will be still there, not cure at all, although we choose the same or the drug of choice, which is the paracetamol. Similarly, for strategic purchasing, if we set price too low, provider will not provide good quality and we will not get efficient. Maybe we will pay in the end much more than if we pay at the right price, but not too much, not too high. So finding the appropriate price is one of the art of strategic purchasing. That's my view. Thank you.
Absolutely. Thank you. And one final question here from Jacques de Claro, who asks, with the current funding available, what is the level of financial protection that it affords to its members, that is BPJS? How does the strategic purchasing reforms deal with this?
Yeah. The protection, the level of protection varies across different groups and regions, because the level of protection is not only influenced by the registration, but also influenced by first the supply side of providers. We do have a shortage of supply side, especially specialist care in many regions, because historically we have been under supply of those services in underdeveloped regions when we have system of mostly market. So those who have money who can buy healthcare in the big city, then healthcare providers move all into the big cities. The small city left behind. Now we provide payment to ensure people in the small city can also get treatment, but the providers not moving back to the small city. So the protection level in that one, although these people in small city already registered, paid the contribution by the government because they are low income, but the supply side not there yet. The second problem is the cultural and individual preference. Many low-income, low-educated people still trust more on traditional medicine, herbal medicine. They're afraid of medical intervention, especially such as surgical procedure. They don't trust, for example, cancer medicine, that they listen from their neighbors or friends that this medicine creates severe consequences. Then they don't use it, although they have the right. So they are not protected. So and therefore we did some studies by my student that this is not representative to all Indonesian, but for several spot check, the protection level overall maybe only is about 40% or 45% of the total people who are registered. So that's the reality that we are facing. Certainly, if those people who are registered use their services, and therefore also related to the question with Louis, our utilization rate remains low to compare to the total population number. Then we might have more problem on the financing side. We might have more severe deficit problem. So that's what I can explain for now.
Perfect, thank you. And another question from Rashid, who asks, how does the government payment of less than $2 per capita per month for the very poor affect the quality of services consumed by purchasers?
As I explained before, it is certainly for the standard of Western or higher developed country or more developed country, certainly the quality level is not at all good enough. But in our system, it is actually $2 or less. It's a partial, because those people who are poor and get subsidy from the government are assigned to the public health centers, which is the public health center already also receiving line item budget from local government. So this funding from national government. So they use this public health center. They don't mind to have long queue. They don't mind to go early morning, queue until afternoon. Although the drugs provided mostly generic are maybe good, but in terms of satisfaction, in terms of promptness of the treatment, might not be good enough. So depending on what quality do we mean for? If the quality meaning satisfaction, certainly for the middle income and above, they are not satisfied with the system, but they are not subsidized by the government. For low income, often I did several studies, so I expected that people complaining because I measure with my standards. When I met those people, actually I was surprised that they highly satisfied for hospitalization in public hospital. Because what? Because they normally live in very poor house, and also they might eat meat maybe only once a month. While they are hospitalized, they don't pay contribution. They are treated with doctors and nurses, and they are eating 3 times a day. They're very satisfied. They are very grateful to the government. So that satisfaction level is subjective. We still have a lot of homework to measure quality for that. But for short, certainly quality for lower income still acceptable for them, but not acceptable for middle income and above. And certainly not the same with the quality in the upper middle income countries, not the developed countries. Thank you.
Thank you, Dr. Hasbullah. And the second question from Alex Winch and Michael Borowitz on whether you could comment on dual practice in primary care. And they note that, as you say, the capitation rate is too low. So is there a way to earmark new funds towards primary care based on improved performance? Or is there a political way of prioritizing primary care versus, say, hospital care?
Yeah, thank
Dual practice for the primary care actually has different impact. The public primary care receiving capitation to public health center where the money does not necessarily go adequately to the doctors who are working in the public health center, while in the evening they have private practice. They might be and might not be contracted by the BPJS. If they are contracted, so the money for the private services in the evening all belong to the doctors because the doctors own the facilities and the payments belong to him or to her. This private practice have better performance as in response to capitation compared to the public facilities. But there is no relation with that. I know for some developed countries, this dual practice seems like odd, but for Indonesian, they can separate it, different payment for different money for different services. Certainly, those with dual practice, they prefer to serve the private patient better than the public patient, because if they're losing private patient, they're losing money. If they're losing public patient in the public health center, there is no effect with their income. So that's inappropriate at this time, but we still practice in transition to change to the fully private maybe someday in the future.
Thank you very much, Dr. Hasbullah. That finishes our questions. So there is a problem with Aurelie's browser, so I'll be passing over to Danielle, who will close the session and also give information about the upcoming webinar in September. So Danielle, over to you.
Hey all. Thanks everybody for joining. This has been excellent, and thanks to our speakers as well. So we have the next webinar in this series will be on September 24th, and it's a second part to this topic of quality for health services, looking at strategic purchasing as an instrument to improve quality. And the country of focus will be India. So we will circulate again a WebEx for that upcoming webinar, and look forward to speaking with you all on the 24th.
Thank you very much. Thank you for the question and attention. Thank you. Hope to continue with this sharing.